Bismillah ar-Rahman ar-Rahim. It's our honor and pleasure to record this historical presentation about the history of electrophysiology from our eminent electrophysiologist, cardiologist, and one of the people who paved the way for electrophysiology in Egypt and the Middle East, Professor H Rizk, professor of cardiology at the Cairo University. He is going to give us the presentation about the history of electrophysiology with the title of From the Roots Upward on the Shoulders of Giants. Professor H Rizk, please.
Thank you very much. Bismillah ar-Rahman ar-Rahim. This is a concise history of how we came to know what we know. The sequence of knowledge we got here is shown on this slide. First, the neuromuscular activity had to be identified as electrical. Then there was a debate about whether the contraction of the heart is similar to skeletal muscles, namely neurogenic, or it's an innate phenomenon of the heart muscle, myogenic. We'll discuss in short cardiac activity, neuronal electrical activity, the cell membrane traffic and ion channels, then the structure of the conduction system. Then we'll come to electrocardiography, rhythm disturbances, intracardiac recording, and drug therapy and development. Finally, we'll go to mapping and ablation. We don't have enough time to discuss device development, diagnostics, and therapeutics, so let's leave this to another session. First of all, as old as 1845, Ernest and Friedrich Weber in Germany did an experiment where they stimulated electrically the vagus nerve in animals, and that resulted in slowing or even stopping the heartbeat. And they advocated that the vagus was the cause of heart action, the cause of impulse formation. The reason of this belief was simple. All muscles of the body had nerves, and they function when the nerves are stimulated. The heart is a unique example, and it took some time to grasp this phenomenon. Luigi Galvani, an Italian physician and physicist, made his first experiment, which is application of electric current to the dorsal nerves of a frog preparation. And he found that when electricity stimulates the nerves, the frog moves its muscle. And that was the first hint to the idea that muscular activity is, in fact, an electric phenomenon. This was, again, very old. That was 1750. The cardiac electric mechanical activity became clear after the pioneering experiments of Hermann Stanius. Hermann Stanius brought an isolated, that is denervated, heart of a frog. The heart of a frog has a separate sinus venosus from atria, separated by a sulcus, as seen here. And then the atria are separated from the ventricles by another sulcus, and then the ventricles evacuate into the truncus arteriosus. He first observed that contraction starts from the sinus venosus, then through the atria and ventricles. He said the electric activity or the muscular activity is in the direction of blood flow. When he applied a ligature at the sulcus between the sinus venosus and the atria, which is called the first Stanius ligature, the heart started to follow the atria, but at a slower rate than the sinus venosus. And when he applied a second ligature, the second Stanius ligature, at the sulcus between the atria and the ventricles either stopped completely or resumed contracting at a very slow rate. he proved with this seminal experiment that number one, cardiac activity is definitely myogenic because this heart is denervated. Two, the heart is activated in the direction of blood flow. Three, there is inherent automaticity, each focus in the heart. And last, the fastest focus is in control of the heart. Later, it was found that the contraction waves in mammals were the same from base to apex as in frogs and full-blood animals. That was a breakthrough at its time, 1850. Then we needed a neuron to study the ionic currents and electric activity. There was no such a big neuron available in humans or frogs. However, squid, اللي هو الحبار, doesn't have a brain, but it has a group of nerve cells at the front that give large axons. These axons are really giant by any dimension. Each axon is 1 millimeter in diameter and about 4 centimeters in length. Now we have a single cell which is big enough to study. If they insert now a microelectrode inside the axon and another electrode, whether at the surface of the axon or in the bathing solution, we can measure through a galvanometer the electric potential associated with nerve activity. And that was the first notion of action potential, as it was called at that time. Because it was known for microscopic studies that the cell membrane is a lipid protein bilayer that is insulating to ions, does not allow ions to move. It was assumed at this time that there must exist what's called ion channels. That was long before ion channels were identified under electron microscopy. To study the voltage against the membrane inside or outside, they could differentiate two types of ionic movements, so to speak, two types of ion channels. One of them, when open, it's free leaking. Movement is according to the concentration gradient or electric gradient. Example, the sodium channel. We found another channel which only opens at a fixed transmembrane voltage. This is called a voltage-dependent channel. Example is the calcium channel. By applying an apparatus that delivers electric energy to the inside of the axon, we can fix the transmembrane potential at a certain level. This is called voltage clamp. So at this particular level, for example, the calcium channel opens, we can study the calcium channel. If we go up, the calcium channel is closed and we only can study the sodium channel. The voltage clamp technique, membrane potential is maintained at a constant value determined by the experimenter. That was early before the Second World War. Then, when we knew the traffic of ions, two important scientists, Huxley and Hodgkin, derived a schema of the membrane and reached to the formula which correlates the activity of the ions to the transmembrane potential. And this formula is called the Hodgkin and Huxley equation. This constitutes the central dogma in our understanding of the relation of ion traffic to transmembrane potential. This won these two scientists the Nobel Prize in medicine or physiology, 1952. The patch clamp technique is a further refinement of ion channel examination. With a micropipette that can be applied to the cleaned surface of the cell, you can apply it to a single ion channel. And if you connect the basing solution in the micropipette to a galvanometer, which is very sensitive, able to measure currents even in the range of picoampere, you can study the traffic of ions across a single ion channel. And that was a great advance, the identification of a single ion channel and studying the activity of a single ion channel. And these two scientists, Nair and Sackman, won the Nobel Prize for this invention. Then, with advances in electron microscopy and in genetics, the sequence of the proteins and the nucleic acid formula for the channels started to become identified. 1984, the sodium channel. 1987, the sequence of the calcium channel was known, and later the sequence of the potassium channel was known, which was a third Nobel laureate for this discovery. So now we know that it is electrical. We know the governing rule of the traffic. We know the function of each channel, its voltage relation, and its specific ion relation, and its protein structure. Then we'll talk about the discovery of the conduction system of the heart. The conduction system of the heart was discovered in time frame. First, the distal, strange, then the proximal. First of all, Purkinje described the Purkinje fibers histologically. Then His described the bundle of His. Later, Tavara described the AV node and what he called the bundle of Tavara, which is actually a part of the bundle of His and the right ventricular branch of the bundle of His. The last thing to be discovered was the SA node, and that was discovered by Cave and Flack. So we now know the structure of the conduction system of the heart. Once these things became known, other discoveries followed. Stanley Kent, 1893, found multi and later appeared to be a feature of what will be called the Wolff-Parkinson light syndrome. Mahine described the Mahine fibers. Later, Thomas James described the internodal pathways between the SA node and the AV node, anterior, medial, and posterior internodal pathways. Finally, gap junctions were the last to be identified by Karlovsky, and that was very new, 1967. So we now are clear about the structure of the conduction system and the function. Electrocardiography was based on what is called the volume conductor hypothesis. This hypothesis assumes that the body is a bag of an electrolyte solution, which is in a way correct. The heart is a source of electromotive force situated inside this bag. when the electric activity is in the direction F, it reflects as positive on the surface towards F, negative on the surface away from F, and neutral in the area perpendicular to F. Now, if you apply an electrode to the surface of this volume conductor and connect it to a galvanometer, the galvanometer is going to record an electric deflection. And that deflection will depend on, first of all, the magnitude of the electromotive force. Two, the angle between the direction of activation and the direction of reporting, angle A or angle alpha. And three, of course, the radius, the reverse square law. So D, or deflection, equals force cosine angle alpha divided by R squared. And this volume conductor formula constituted the basis of studying electrocardiography, which is recording the potentials of the heart as projected on the body cells. Desiree Waller recorded the first ECG from the human body using a very relatively crude method of measuring electricity. It's called the capillary electrometer, which was designed by Lippmann. And electrodes were strapped to the front and back of the chest, while putting the patient's extremities in saline jars for airflow. Now, this electrocardiogram was not sensitive enough to detect the P wave. It was only able to detect ventricular depolarization and ventricular repolarization. P waves could not be detected. Einthoven started later by the capillary electrometer, but he soon discovered its limitation. He later used the string galvanometer, which was a breakthrough in the design of an electrocardiogram machine that time. It was invented for purposes of precise current measurement by Clement Adler, 1897. Wilhelm Einthoven was awarded the Nobel Prize of Medicine for the discovery of the electrocardiograph. No one actually knows why did he call his waves P, Q, R, S, and T. The reason is not clear, but that's how he called it. The early machine of Einthoven weighed 600 pounds, approximately 300 kilograms, and it needed 5 operators. The patient had to put 2 hands and 1 foot in an electrolyte solution to finally obtain only a 3D electrocardiogram. And you know, of course, how small, how accurate, how complete the electrocardiogram has developed to become these days. This is a memorial post stamp. Robert Adam, before discovering the electrocardiogram, associated syncope with heart block, very slow pulse and loss of consciousness. William Stoke reported again heart block associated with syncopal attacks. As you see, the dates here are well before the electrocardiogram. And then it became clear when we have the electrocardiogram that the AV block was the reason for this syncope. Lewis Wolf, together with Parkinson and Paul Dudley White, described the Wolff-Parkinson-White syndrome in 1930. And I was very curious to know what was a Wolff-Parkinson-White syndrome called when encountered on the ECG before the term Wolff-Parkinson-White syndrome was identified. I actually came across a very rare electrocardiogram with Wolff-Parkinson-White syndrome. And the report on it read left bundle branch block, short PR, and between brackets, very strange. Extremely rare observation. Paul Dudley White wrote his first book on heart disease in 1931, and that was the first cardiology book to include a chapter on the electrocardiogram. Carl Friedrich Wenckebach is a genius, Dutch anatomist and clinician. He described progressive AV block until a drop in a ventricular beat occurred. And this again was described before we have the electrocardiogram. And if you want to know how he first described it, is he reports a patient with progressively diminishing intensity of the first heart sound, presumably due to the longer PR interval, until a beat is dropped, and then the next beat has a strong first heart sound again. When he studied this with the pulse measurement, there was a machine that measures at that time both arterial pulse and venous pulse. It was called the Etienne Marie Tampour or Etienne Marie pulse recorder. He could connect this to a prolongation of the PA interval. That was, of course, documented when the electrocardiogram came about. In 1924, Mobitz came, and he could identify and differentiate two types of secondary PET block, of which Mobitz type 1 was identical to the previously described type by Wenckebach. And so by 1924, we could identify first degree heart block, and we could identify second degree heart block, two types, and we could identify third degree heart block and Stokes-Adams attack. And starting 1930, the term Wolff-Parkinson-White syndrome was in. James Mackenzie came before the electrocardiogram. He wrote a textbook on cardiology with one page on the electrocardiography, which he considered to be less important than the pulse recording by Etienne Marie. Then William Einthoven, and of course Thomas Lewis, who devised the Lewis ladder grams, as we shall see. Einthoven traced gradual prolongation of the PR interval and confirmed the Wenckebach phenomenon. Then two scientists, Jarvel and Lang-Nielsen, reported a Norwegian family with syncopal arrhythmia, QT interval prolongation, and congenital deafness. Then, independent from one another, Romano and Ward, Romano in Italy and Ward in Ireland, described a family of prolonged QT intervals, syncopal attacks, and sudden death. The exact mechanism of sudden death was later identified by Dessertin, 1966, who recorded and described Torsat de Roy. Regarding Holter, Norman Holter in 1947 invented the ambulatory ECG. Norman Holter visited Egypt, and in a lecture he showed a picture of his machine, which was a big bag on the back, and the first machine was 38 kilograms. You know now what Holters are. Actually, Holter, in collaboration with a physicist and later on a space scientist, Bruce Delmar of Delmar Avionics, made the current modern recorder that we see, and the recording evolved from tape to chip to wireless transmission, as you know. Invasive electrophysiology started in the early 60s with the invention of the intracardiac electrode catheter. The intracardiac electrode catheter was a natural extension of the discovery of cardiac catheterization by Prosper. This example is a patient with supraventricular tachycardia and AV Wenckebach, together with right bundle branch block aberration, of course. The Lewis ladder gram, is a method that was devised by Frank and Lewis to explain or to simplify the flow of impulses from the atria to the ventricle and the reverse. You can see the prolongation of the PR interval here, and then a blocked bead, and then it conducts normally again. I want you to think of invasive EPS recording as a Lewis laddergram, which is recorded instead of deduced. We are no more willing to calculate it. We can see it on the paper, and that is invasive electrophysiology. Durer and Willems described arrhythmias being initiated and terminated by programmed electrical stimulation in Wolff-Parkinson-White syndrome, 1967. Comel reported a similar phenomenon, but this time in patients with evinodal reentrant tachycardia. EPS was first used to identify and initiate and terminate reentrant tachycardia, then to induce ventricular tachycardia, elucidate Wolff-Parkinson-White mechanism, and of course to study later the effect of drugs. Secondary to that, the first surgical interruption of the bundle of Kent using epicardial mapping took place in 1968. A breakthrough in invasive electrophysiology was the ability of Benjamin Sherlock in 1969 to record clearly and consistently the His bundle potential in humans. And that was extremely important because now it helped to identify the level of AV block. It helped to identify and localize His bundle pre-excitation. It helped to diagnose pre-excitation by giving a stimulus at a time where this is refractory, and it had many, many repercussions on invasive electrophysiology. Matter of fact, invasive electrophysiology can be divided into two stages: مرحلة ما قبل الهيس بندل electrogram ومرحلة ما بعد الهيس بندل electrogram. Now, if you combine the 12-lead ECG during the arrhythmia and the data obtained by programmed electrical stimulation, you can see a wealth of information. Henry Marriott and Hein Willems clarified the origin of different forms of white QRS tachycardia. Then the ARVD was described by that, and we wrote on together with Fontaine and Mark Josephson of Pennsylvania, made mapping and subsequently made surgery for ventricular tachycardia feasible. Mark Josephson identified the pathogenesis of ventricular tachycardia after myocardial infarction. He was one of the early users of the term arrhythmia substrate, and he delineated methods of mapping arrhythmia that were later used to adapt. One important trial caused a paradigm shift in relation to our understanding of drug treatment of cardiac arrhythmia. Before CAST, we thought that suppression of ectopic beats is going to produce a good result. There was a pilot study, which is called the CAPS, Cardiac Arrhythmia Pilot Study, where three drugs in the class 1C, inquinine, flecainide, and morisazine, were studied in patients with post-myocardial infarction, impaired left ventricle, and frequent ventricular extrasystoles. And it was found that these drugs actually are able to suppress ventricular. So it was tried to identify now whether suppression of these extrasystoles helps patients' mortality or not. And the discovery came when the patients on placebo actually did better than patients on active treatment, inquinine or flecainide. Now we know that effective 1C agent can suppress ectopy, but as a matter of fact, it increases, not decreases mortality, and that was very highly significant. Morphine, the third drug, was tried in another trial, the CAST-2, which was again stopped prematurely because of excessive mortality in the active limb. When you examine the effect on the substrate, you find that patients only with a broad QRS more than 0.1, if they are on placebo, they do much better than if they are on the active treatment. Regarding heart failure, patients who needed diuretics did better on placebo than on active treatment. And regarding ischemia, patients with active ischemia did better on placebo than on active treatment. So now we know that the so-called pro-arrhythmic effect of this class is enhanced by heart failure, by ischemia, and by pre-existing intraventricular conduction effect, as evidenced by a broader QRS complex. So we now know that the requisites of a sustained reentrant arrhythmia are not simply ectopy. We know that a substrate is important together with a trigger and an environment, MEA, which is maybe excessive sympathetic stimulation, maybe electrolyte disturbance, etc. We also identified the importance of the left ventricular ejection fraction, and we learned to be very cautious about the use of class 1C agents, which are very potent sodium channel blockers. Now, sorry, regarding atrial fibrillation, that was the last arrhythmia we addressed. First of all, attempts at surgical ablation using the Mays procedure for atrial fibrillation, 1989. Schwartz described catheter-based radiofrequency chronic AF ablation. And Hasseger used multiple electrode mapping techniques to map the pattern of arrhythmogenic foci of genetic atrial fibrillation and ablation with the local radiofrequency energy in foci in the pulmonary veins. Compare that to the ease with which the new devices do this. Cox-Maze was performed with cryoablation, 1999. Actually, Cox adapted this technique based on the works of Hasseger, and there is now a minimally invasive surgical procedure for surgical Cox-Maze applied at a minimally invasive right intercostal approach. Ventricular tachycardia. Excision of the left ventricular aneurysm was first devised in 1959. Mark Josephson, because he could identify that the arrhythmia starts mainly subendocardial, started to do subendocardial resection for treating ventricular tachycardia in patients with ventricular aneurysm and ischemic heart disease. There were different cuts, either a complete encircling endoventriculotomy or incomplete, and this technique continued to be used for some time. DC shock, astonishingly, was first used as VT ablation. That was before radiofrequency energy. The story of use of DC shock in arrhythmia ablation started by chance. A patient had a catheter in the AV lesion, which accidentally contacted a cardioverter electrode. And when the paddle electrode was discharged, the electricity through the catheter caused AV block. And that was the origin of the first ablation by DC shock for AV block. Then endocardial DC shock was also tried as VT ablation. Late in 80s, this was switched to, of course, radiofrequency energy, as you know. VT ablation guided by circuit mapping was a newer innovation, and for non-ischemic VT, where the substrate may be actually epicardial, Eduardo Sosa introduced the technique of percutaneous epicardial access for mapping and ablation of arrhythmia that is mainly epicardial. We can see this now, for example, in Brugada. This was the latest innovation, of course. Carlo Paponi introduced electroanatomical non-fluoroscopic mapping system. This is an example of a mapped left ventricular scar. And that was the most recent thing, combining electrocardiography to magnetic resonance imaging, and that was to identify the areas of delayed activity in patients with, and that's where we are now. If we wish to discuss the development and use of cardiac implantable electronic devices, that can be the subject of another talk. And thank you very much.
Thank you very much, Professor H Rizk, for this historical presentation dealing with the development of electrophysiology from cell site up to the highest technology integrated together. And we will meet you again with the devices and their development in the next session. Thank you very much, Professor H Rizk.
Thank you.